with the traumatic spondyloptosis of the C2 or C2 Hangman's injury with the concomitant retrolistheis of C5 to C6 vertebrae. So the patient sustained her injuries after the vehicle fell off of the cliff early in the morning, and the pictures shows how the vehicle looked like at the site. There was note of transient loss of consciousness, and there were hypotensive episodes. And then the patient was brought to a local hospital. They did a fluid resuscitation. They noticed a neck tenderness, and the patient was unable to move both of her lower extremities, hence referred to a higher center. She arrived at the ER conscious, coherent, with the following vital signs. And there was bilateral upper extremity weakness with no motor functions on both of her lower extremities. However, perianal sensation was present, bulbocavernosus reflex, and bilateral ankle clonus were noted. Extraspinal workup and findings were managed conservatively. And on cervical X-ray, there were bilateral pedicle fractures of the C2 with spondyloptosis of the vertebra over the C3 vertebrae. And additional findings we've seen on CT scan, there was a burst fracture of C5 with subluxation over C6 causing spinal canal stenosis. So this is the eggshell view of the CT scan, and the top three pictures show the eggshell cut at C2 level with the fracture patterns. Below shows the cut at C5 level with the fracture patterns. On MRI, there was a cervical cord compression at the level of C5-C6 brought about by the subluxation of the respective vertebrae. And based on Levine and Edwards' classification of Hangman's fracture, this would be classified as type 2 with more than 3 mm displacement on the patient is around 1 cm or 10 mm. And basing on AO classification, it will be classified as type C with the translation of the vertebral body. For the subaxial injury at C5-C6, it is classified as type F4 due to the subluxation of C5 over C6. And then for the subaxial injury classification and the severity score or SLIC score, we got a total score of 10, which is warranting a surgical intervention. And given the physical examinations and imaging findings, this will be our final diagnosis. This was the initial management that was done at the ER. ABCs were checked and managed accordingly, and we placed the cervical collar in situ without reduction, and maintaining the mean arterial pressure at more than 85 mm mercury, and the timely administration of the methylprednisolone following the NASTIS 3 protocol. Inside the theater, awake video-assisted intubation was done, avoiding hyperextension of the cervical spine. And Mayfield tongue was applied once the anesthetics were given, and the patient was positioned on prone on the spinal table. C-arm images were taken, and the spondyloptosis was partially reduced, which meant the cervical spine was unstable. So the surgery was done at 22 hours post-injury. And we did a open reduction of C2 to C3 with posterior decompression at C3 to C6, and instrumented fusion by inserting lateral screws at C1 and C3, and pedicle screws at C2, C5, C6, and C7 under navigation surgery. So this is our post-op X-ray. Post-operatively, the patient was placed in the critical care unit, and still we maintained the map at more than 85 mm mercury, and she was initially placed on ventilatory support and was later weaned off. DVT prophylaxis and physiotherapy was then initiated. This is our patient on the 7th day post-op in her room. Note the active ROMs of the elbows and shoulders. And with the progression of rehab, it is our patient 2 weeks at the rehab unit. She was then discharged after the 3rd week from surgery and with the following instructions. This is the video sent by our patient on her 2nd month after the surgery. And at present, these are the things that she can also do at 6 months from the surgery. Shown are the consecutive x-rays from the time of injury at 2 weeks post-op and then 6 months post-op with the alignment of the spine by the screws and rods. And what we would like to highlight here is that the first 24 to 36 hours after injury is a crucial time in which the patient can benefit and achieve optimal neurologic recovery from a decompressive surgery. As for the issue on closed reduction versus open reduction in treating cervical spinal fracture dislocation, early closed reduction is recommended. However, it may not always be successful all the time. And even after a closed reduction is done, an open internal fixation would still be necessary. That's why we opted for open reduction. It is also important to maintain the mean arterial pressure at 85 millimeter mercury to maintain the spinal cord perfusion and for neurological recovery. And lastly, we would like to emphasize the timely administration of methylprednisolone in selected patients, as mentioned in the published AO spine clinical practice guidelines. So these are the recommendations for not giving a 24-hour infusion of high-dose methylprednisolone for patients presenting to the ER after 8 hours from injury. Also not giving a 48-hour infusion of high-dose methylprednisolone to patients after spinal cord injury, but giving a 24-hour infusion of high-dose methylprednisolone to patients presenting within 8 hours from spinal cord injury. So that's all.
Thank you, Dr. Wooden. The floor is now open for questions. Yes, Dr. Ray.
Hello. My question is, how did the alignment look like when you did the initial reduction after intubation?
After intubation, we haven't done a X-ray after that. But after positioning the patient on prone position, we have already noted that the spondyloptosis have initially reduced.
Okay, so basically the main method of reduction was after the prone positioning.
Yes.
Okay. My question is that with regards to, technically you have two different problems, right? You have the one, you have the Hangman's fracture at C2, which is a type 2,
yes.
And you have the 5-6, wherein I think that's where most of the neurologic deficits came from.
Yes.
I understand that you did a C1 to 7 fusion, which is relatively a long construct as well. My question is that, probably, in my opinion, after when you guys did the initial intubation, I would have probably taken an X-ray, saw how it would have reduced, because probably if the C2 Hangman's fracture reduced quite well after intubation and on supine positioning, my first initial inkling would be to probably do it from the front and do a single ACDF at C2-3, and then go to the back, do the 5-6, kasi even if the 5-6 you were able to reduce it, okay then. I think you could have done like a single level fusion also at 5-6 na separate. without having to, kumbaga, instrument the entire thing on the back. But the problem really will be, even if you do it from the front, yung 5-6 kasi medyo questionable since it is a retrolisthesis. So probably ako, I would have gone into looking if I could have saved fusion from C1 to 3 and just fused yung C4, 5, 6, 7 from the back. Para hindi yung buong thing ng neck way up to C1, wherein the problem really with C1 fusion and C2 is yung fusion rates later on. I don't know if on the how you did the fusion on C12, kung naglagay ba kayo ng iliac crest na like a Gailey type of fusion, no? Because that is usually where the problem will be in fusing that uppermost level. So yun lang. But it was a great case.
Yes, thank you for the comment. But for our point of view at that time, we actually had the pressure of decompressing the spinal cord since we are at 22 hours from injury. So we are actually parang hinahabol namin yung 24 hours the critical period. So we opted for a posterior approach to have a faster way of decompressing the spinal cord at C5-C6 initially. And then from that, we decided to fuse it as one long strap. And then actually, ideal is we plan to do a anterior approach after the posterior instrumentation. However, we had it. We plan to observe the strength or the stability of the posterior instrumentation that we did, and so far there was no failure for the 6 months follow-up. So we're still observing for further stabilization of the construct.
Thank you. Taking the cue from Dr. Ver, would anybody in the group do close reduction initially? Like if you would have some delay with the actual surgery, so would anybody do close reduction initially? Yes, Dr. Chongsan.
I think the comment of Dr. Ver is very relevant. Now, usually the patient comes to us is quite late. It's past the golden period. So, what I would do is I would try to do a close reduction. Now, once it is reduced, because the insult to the cord is already there, there's no need to decompress or whatever. By merely reducing the dislocation, you are decompressing the cord. Now, once it is reduced, let nature take over. Then you wait for a while, so you can save the length of the fusion. You can just do segment 2-3, then 5-6 later, because the neck needs mobility. With this construct, you have a stiff neck. So the patient is doomed to have a stiff neck for the rest of her natural life. So I think being patient will be very prudent for this case. Anyway, she is showing signs of improvement. So what do we have to be to rush in, fix everything?
Just a concern with reduction. Let's say if we put the patient on traction, would the pan-vertebral affectation of C2, would it afford a good traction on the C5 first fracture?
Yes, Doc, that's actually one issue for us in deciding in doing a close reduction, because the problem is we have two concomitant injuries. In the C2 may really compromise the effect of the close reduction on C5 over C6, and actually there were haven't read any article that's really saying the effectiveness of close reduction on concomitant cervical injuries. Yeah.
Yes, Dr. Dave.
Yeah, I would actually agree with that statement. I would think that we might that the patient that the C2-3 injury might actually over distract first before you get any form of reduction dun sa C5-C6 if you apply inline traction. So chances are I probably would do an open reduction at the soonest possible. I don't think a closed reduction would be possible in this particular case.
Yes, Dr. Bear?
Again, nice case. Just a question, especially my colleagues can answer. For those who are doing spine surgeries with intraspinal cord monitoring, when you know at least in this patient, the level of neurologic deficit is probably due to the lower level C5-C6 and not at the Hangman's fracture, isn't it? Will
Yes.
you be if you have the intraspinal cord monitoring and say already in sa-op and you're able to reduce the Hangman and signal wise there is no problem, okay, will you be doing conservative for the Hangman and just tackle the C5-C6? The other question is, in most cases of course, this is retrolisthesis. There are usually neurologic deficit that you attribute it to probably your disc problem or herniation. I did not see it clearly. Was there a disc problem that has thecal sac indentation
It's more of the subluxation of the vertebral column.
and no disc herniation?
None.
And that's the reason why you not because it's usual if there's discrimination, the automatic approach will be anterior.
Yes, sir.
Correct. So, but anyway, my question for those, if you are doing it with intraspinal cord monitoring, will you be managing the Hangman's conservatively and just do the lower cervical?
May I answer? Actually, I am doing a case report official for this, and on my readings for the type 2 hangmans, they actually suggest a halo traction for these cases. However, an author, Dr. Samaha, who wrote an article regarding type 2 hangman's fracture, suggested a surgical intervention when the translation is more than 3 millimeter, or if there's a great angle of kyphosis or lordosis, which will really lead to the instability of the hangman's fracture. So I think even with the normal or unremarkable intra-op monitoring for the reduction, I think in this case we still need to fuse the hangman's fracture.
Thank you, Dr. Wooden. We have 4 more minutes. Yes?
Good morning. I'm Dr. Martinez from Baguio General Hospital. Actually, this is just maybe a comment and I would like to share. I attended recently the CICOT Congress and I attended the plenary about multiply injured patients. And there was comments about the use of methylprednisolone. So there was a show of hands from different surgeons from all over the world, and actually, they are not using it already. So it's quite so the goal of the team is to, yes, the immediate intervention. So it's not about the methylprednisolone already. So most of them show of hands that they are not using anymore steroid, because most of our patients would be probably multiply injured and it will compromise the recovery of the patients. And one important thing is that if the patient had spine injury with concomitant surgical blood injuries, so what they said that it's very important to stabilize the spine and go back to the other injuries if possible. So parang naano kami na very aggressive ang mga spine surgeons because the outcome long term will be very vital. So again, the advice was to do immediate intervention for SCI patients or these multiply injured patients. So, yun, nakakatawa nga sir, talagang pina-pull out na daw sa market, especially in Europe, metroprednisolone in the use of Pilates. Thank you, thank you.
Thank you for those inputs. Any more? Yeah, just for Dr. Wooden, the point of Dr. Bear, the presence of your critical disc herniation, which I think is one of your modifiers for your subaxial spine classification. I think that's very important because I think you have a critical disc herniation in this case. So, any more? If there are none, then Dr. Wooden, thank you very much for presenting that very interesting case. And we will now move on to our brunch symposium. So thank you very much.